As healthcare moves away from traditional fee-for-service models, providers need a strategy to stay competitive. That's where Strategic Healthcare Partners comes in. We offer expert consulting and ongoing management oversight for providers looking to form an accountable care organization. From financial feasibility analysis to helping you choose the right ACO in a crowded market, SHP provides the clarity you need to make informed decisions and transition to value-based care. Learn more at shpllc.com. Welcome to Beyond the Stethoscope, Vital Conversations with SHP. We're busy gearing up for Season 3.
In the meantime, enjoy this greatest hit episode from our archives.
We hope you enjoy it. We look forward to you joining us on October 11th as we kick off Season 3. Welcome to Beyond the Stethoscope, Vital Conversations with SHP. I'm Jason Crosby. In today's news, Aaron Higgins and I share articles about how our providers and children are burning out, and then the Biden administration is preparing cybersecurity rules and requirements for healthcare facilities. Then in today's interview, we are joined by Sean Cavanaugh, CPO for Aledade. Previously, he served as Deputy Administrator and Director of the Center for Medicare at CMS. In this special two-part series, you'll hear his viewpoint related to today's independent primary care physician, the impact of value-based care, and how Aledade supports their practices for success in their ACO. Are you ready for this vital conversation? Let's get going.
Hey there, Jason. How are you doing today?
Hey, Aaron. Good morning. Good to talk to you.
Yeah, it's a little chilly here in the deep south. For our listening audience, it's we're in the Savannah area, and it's actually below 60 degrees. In fact, I think it's in the high 30s, which is a little unusual for this time of year. So it's definitely a coffee morning. So, Jason, we got a couple headlines I think we wanted to talk about today. So first, I think the audience is very quickly learning I'm very nerdy and definitely involved heavily in IT. So this headline really jumped out at me because it kind of pivots off the other two headlines I've talked about in the last few episodes. And that's in regards to the Biden administration has announced that they've directed Health and Human Services to draft up cybersecurity rules for hospitals as well as medical devices. And that's kind of a big thing. There's been obviously a lot of ransomware attacks and cyber attacks against healthcare organizations, but we're also seeing an expansion of attacks against personal devices. Things like defibrillators, insulin pumps, those devices that we are becoming more and more reliant upon. They're not built with security in mind. So HHS has been directed to draft some rules. We're going to start seeing those rules sometime next year, judging by what is being said by HHS. So what does this mean for our listeners? It means our listeners are going to need to start beefing up security. I think no matter what size organization you are, there's going to be some very strict rules about what level of security your organization is going to have. And I also feel like there's going to be some very steep deadlines, because really at this point, we're 20 years into using EMRs, 10 years in those EMRs being widespread. It's really time that security on this is taken very seriously. So yeah, any thoughts on that, Jason?
Yeah, well, we touched on last week or two on cybersecurity insurance premiums, just as you mentioned there, with costs going up. And read something recently where they do anticipate the previous 2-year trend to continue in the year 3 for 2023 of that 30+ premium hike. And I think it just further validates what you're stating that needs to happen, right? If there are trends in place, cybersecurity attacks, insurance premiums are going up, it's only going to continue. So you're going through budget process now in October. If you're a calendar year, fiscal year, just go ahead and incorporate this for the next couple of years, I would think.
Yeah, honestly, I mean, I don't know how much you're spending on your cyber or your IT operations, but I would expect as much as doubling what you're spending now. Um, Cybersecurity products are never cheap, but it's one of those things where it's cheaper to pay for it now when it's not a problem than it is to try to fix or pay ransom after you get hit. So, Jason, what headlines do you have?
Trend that we've been aware of, just similar to what you're stating there for the last couple of years, but on the provider side, a recent survey released on physicians leaving the workforce. Right now, there's some numbers that apply to a 2021 report that shows over 330,000 healthcare providers leaving the workforce completely last year, right? And your typical reasons being, retirement, burnout, and of course other stressors related to the pandemic. But what gets most concerning is a little over a third of that are on the physician side. And so we know there's an aging physician population. We've got stressors coming into place, right? We've got a boomer population. It's just more alarming when you see those numbers getting that large this quickly. And then you follow that with over 50,000 being, nurse practitioners and PAs, and then another 20 plus thousand in the other disciplines, physical therapy, occupational therapy, clinical, licensed social workers. And so it just goes down and down the line there. That gets a little bit more concerning, like I mentioned before. And then we'll peel the onion back a little bit, and this is going to tie into our upcoming podcast with Sean, is what further dive into the physician number. And when you look at that, you're looking at between internal med and family practice, you're looking at around 30,000 physicians leaving. Very alarming, right? And then another 10,000 plus on the clinical psychology side. And like I mentioned before, not far behind them is on the PT and clinical social workers. And so what do we do about that? It doesn't help that it further mentions your average pulmonologist spending 20% of time on administrative tasks, right? You've got, of course, the trend of independence to employed physicians. And then lastly, and we've seen this with travel nurses, especially the last couple of years throughout the pandemic, is what's being spent on contract labor, right? Those expenses have been through the roof. And so there's almost this perfect storm of stressors, financial woes, especially on the health system side, stretched out providers, and what's in the queue is the other question that the survey is asking, and we're not quite sure what's going to fill these voids. And we've talked before, you and I, about technology enabling firms, right? Whether it's been Amazon, Walmart, Best Buy, even, all the RPM vendors, telehealth, etc. Is that what's going to fill the void more so than your next physician? Time will tell, but yeah, and so that feeds into another article you sent recently, Aaron, that really caught, I think, both of us personally, was just the trend in youth mental health, right? Well, if that trend's going up and we're seeing physicians and clinical licensed social workers depleting, once again, we have sort of that perfect storm of patient need equaling, less providers to help treat them. So just a big concern there. And that's my news blitz for the day.
Boy, man. Honestly, both of these stories aren't terribly uplifting. we need to do a better job at finding some of happy news in healthcare. But these are both very concerning. It's definitely a growing crisis, and I hate to throw out that word crisis, but it is. It's a mental health crisis that's hitting our kids, which is super important, but then the providers themselves. If the providers themselves aren't mentally healthy, how can we expect them to help the kids? So that's definitely a concern. Oh boy, so something to think about, and maybe take back to our boardrooms to discuss ways that we can help with this. So Jason, tell us about our interview today.
Yeah, we're followed with another two-parter. Part one, being today, is with Sean Cavanaugh, who is Chief Commercial Officer, Chief Policy Officer with Aledade, and also a former director with CMS. talks a lot about value-based care, ACO world, and some of the topics we touched on. So very excited to have Sean.
That's great. Alrighty, well, I look forward to listening to it. We'll talk to you soon.
Great. Thanks, Aaron. Hey, everyone. Welcome to Beyond the Stethoscope, Vital Conversations with SHP. I'm Jason Crosby of Strategic Healthcare Partners, alongside our principals, Mike Scribner and John Crew, your hosts for today's episode. Today, our guest is Sean Cavanaugh, Chief Policy Officer and Chief Commercial Officer for Aledade, who for the last several years have provided the technology and services to independent physicians as part of their successful ACO ventures. Previously, he served as the Deputy Administrator and Director of the Center for Medicare at CMS. Sean, thanks for joining us today and welcome to the podcast.
Thanks for having me, guys.
So with that, we'll jump right on the conversation. We'll start off with John first.
Thanks. This is John. Sean, we appreciate you being with us today. Question I have first is, and I think as Georgia experience as well as nationally, we're seeing primary care diminish, independent primary care physicians diminish. We're seeing more and more of the young residents coming out or preferring the employment model. When you look long-term at value-based care models, do you see a direct line where you would be working eventually with employed physicians in these models?
Yeah, I think anybody who's committed to improving healthcare, which means doing what's right for the patient, working within a business model where you get rewarded for preventing a hospitalization rather than doing a hospitalization, I think we'd be willing to work with them, and I think anybody should be willing to work with them. As you correctly point out, in my current position with Aledade, we've very much focused on the independent primary care doc, and that's because of alignment. We think they're already there in their mindset. They're fully aligned with value-based care and doing the right thing by the patient. I think, and you've probably experienced this, for hospitals, I have a lot of sympathy for hospitals. They're in a difficult position as the world transitions to value-based care. If we're really going to reduce hospitalizations, how do they change their business model? It's not as simple as it is for independent physicians. But in the long run, I think they're going to get there, and I think we'll be happy to work with them. And not just us, we're not the only value-based company out there. Some already work with hospitals with some success. If this movement to value-based care is going to work, it's going to have to include everybody. Aledade's starting with the independent primary care physician because we think there's where you get the best alignment initially.
Sean, when you think about the independent primary care that most interest Aledade, what are the characteristics of them that kind of lead you to believe that they're going to be most successful with VBC in the first place?
Mike, thanks for that question. We get that question often from insurers as well. Like, are you guys, going in and finding the elite, high-performing primary care practices and forming like a specialized, high-value network? And we're not taking just the high performers. One thing we look for is some basics. People need to be on an electronic health record, which most people are, but not everybody. They need to have a pretty good track record as far as program integrity, not prescribing tons of opioids. But those are fairly low bars, hopefully. Beyond that, what we're looking for is, practices that are tied to their community, that know their patients, that are looking for a better way to deliver care and are willing to consider the use, our tools. As we provide some data and analytics and some workflow tools to the practices. What we find is if they give the tools a chance, they love them, and then it doesn't take any coaching to get them to use them. But that's what we're looking for. Someone who's willing to try something a little bit different and, do the right work for their patients. And what we find is typically with independent practices, they feel like they're doing that already. And so we're enhancing their ability to do it.
Can you talk a little bit more about the kind of tools that y'all do provide and the things that enhance the practice's ability to be successful?
Sure. What I usually say is it boils down to two buckets. One is who's not in your practice that should be in your practice today, right? Rather than sitting and waiting for someone to come in, we're going to give you data about your whole population, but not just dump a bunch of data on you. We're going to show you very specifically who just got discharged from the hospital yesterday that you should be reaching out to today. there's all sorts of evidence that patients that get discharged from the hospital, if they see their primary care physician within a couple of days, much lower readmission rates. Better for the patient, better for Medicare, better for the practice. In fact, I'll tell you, Mike, a little story, a true story from you heard at the outset that I used to work at CMS. When I was at CMS, there was studies coming out showing just that. Transitional care works. Patient gets discharged from hospital. Some see their PCP. They do better than those who don't. So we created a new billing code in Medicare called Transitional Care Management that specifically pays for practices to see those patients and pays pretty well, I think, compared to some other visits. Then we waited 2 years and we looked at the data and no one was using the code. So, the greatest plans coming to failure. So I went around to the physician groups and I asked them, why isn't anybody using the code? The first thing I heard from, the family physicians, the internists was, we don't know when our patient's been discharged from the hospital. How are we supposed to do that? So sometimes it's as simple as that, tapping into the local HIE, tapping into directly to the hospitals, and not just, creating a very simple way for the practice to come in, turn on their computer in the morning, get a list of patients who left the hospital yesterday, their phone numbers, and a work list. Call these people, bring them in. So like I said, the first thing is giving you an understanding of what's happening to the patients who aren't in the practice, a lot of data analytics to show you which ones really could use some help if you reached out to them. The second bucket is we know who's coming into your practice today and who's in a value-based contract. What's the most important thing for you to know about these patients? What are the quality gaps they haven't had filled? What hospitalizations have they had recently? What specialists are they seeing? How many times if the PCP knew you were seeing 3 cardiologists, he or she couldn't do something about that. So we give this 360-degree view to PCPs. We let them do what they do best, which is provide great primary care. We don't, interfere with how they practice medicine. They know what's best, but we're making sure they're seeing the right patients at the right time.
Sean, to that effect, data to be actionable, data needs to be as current as it can. Can you share a little bit about how you receive data and then how you disseminate that back to practices as real time as possible?
Yeah, John, you're exactly right. The ability to take timely action is only as good as the data you've got. First of all, the tool we give practices, and we literally give it to them, called the Aledade app, it ingests data from numerous sources. So first of all, we get claims data from the payers we have partnerships with. And sometimes that's Medicare, sometimes it's, a commercial insurer. We get notifications, as I said, of admissions and discharges and transfers from the local HIE or directly from hospitals. We get lab results from the major lab companies. Just massive, script Part D results on drug utilization, massive amounts of data. But as you said, what we're constantly fighting is the battle to get it faster and more accurate. Because finding something out, claims data can be 2 months lagged. Ironically, one of the things we found, and I'm a little bit proud of this having come out of CMS, is the data we get the fastest from a payer on a claims data tends to come from Medicare itself. And we've been talking to, the big insurers, United, Aetna, and those guys, and saying, come on, guys, you got to be able to beat the government, right? And the thing is, they have these huge legacy systems that they're all working to upgrade. But what we try to convince them is it's in your interest too. The sooner these doctors know what's going on with the patients, the better the care your members will get. But we do have, at times, we can only be as fast as the payer partners, but we try to get as timely data as possible.
Sean, as the ACOs, have matured that you guys operate, has it been more difficult to, when you get past the low-hanging fruit, is it a little bit tougher to plow the ground to continue to have success, or does it catch a flow that just continues to improve?
Yeah, that's a very fair question. If we're only getting low-hanging fruit, there's more low-hanging fruit than I thought, because we're still improving. Even our earliest ACOs, which started in 2015, they're still getting incremental improvements. I think part of what you see is it takes time. Like anybody who's thinking that this will turn around and a dime is wrong. When we did a study and we've updated it several times. We looked at 5 different ACOs. We started in 5 very different states across the country back in 2016. And we followed them every year since then. And this is a study. This is not using CMS data. This is us using all Medicare claims data, matching those people against similar beneficiaries in their community. And we see consistently every year the same result and continuing to grow, which is people in an Aledade ACO get more primary care. So I think we're up to, in the 4th year, it's 35% more than similar beneficiaries in the community. 35% more primary care. And what that leads to is about 14% fewer ED visits, about 15% fewer inpatient visits. We haven't plateaued yet. It is plausible, but that's why one of the things we're thinking about is like, what's the second engine? Like, how do we expand the ability of these practices to do more? Physicians and their staff only have so much time in the day. Are there services we could augment to help them? So until today, Aledade has always focused our services on the practice. What can we do for the practice? We've now created a subsidiary called Aledade Care Solutions, which will be patient-focused. What can we do directly for the patient? But this is where there's an important distinction between us and Optum and some others. We're going to do it in partnership with the practice. The practice will get to decide when the Aledade services are used, who they're used for, and any data we collect about patients by servicing them directly will go directly back to the PCP, because we think that's key. Keep the PCP in the driver's seat. So to go back to your question, Mike, yeah, there's probably low-hanging fruit out there, but there's a lot of it. We're still working on that. And as we do, like, the problem with the phrase low-hanging fruit, you forget these are patients. They're getting better care. Like, they're going to the hospital less. So that's important. But we think with adding some services and helping the practices directly with patients, we'll be able to move beyond that too.
Sean, when you have markets that aren't as sophisticated as other in terms of the growth of value-based care, and you come into it, there's this perception, right, wrong, or indifferent by providers that this is going to change my workflows within my practice. It's going to be more time consuming. I'm going to have to hire more people, and so I may or may not see a return. I'm sure you've been exposed to that. How do you deal with that as you first come in and working with providers to introduce them to the value-based model?
First of all, we tell them we do have no interest in blowing up your practice and making your life miserable. We're going to take you stepwise through this. We're going to take you through different steps you can do incrementally. We're not going to throw the whole playbook at you on day one. So things will change, because let's be honest, rather than churning patients through the practice, like when you need to make more money, right now your incentive is to see more patients for a shorter period of time, to see the less difficult patients. Over time, not on day one, your business model is going to change where you're going to want to focus on the harder patients. You're going to want to refer out less when you're capable of treating them. But that'll happen gradually over time. The other thing we tell them is there's some things that help you along the way. Our practices, when we have them doing more transitional care visits, more annual wellness visits, they see their Medicare fee-for-service revenue going up day one. So what we call good fee-for-service. Like if you're doing these good preventive services, you can see practice revenue going up 10, 15% before you get a shared savings check. So there is a transition here that we can work with practices. I know you guys have done the same. It's not turning things on a dime, and it's not like seeing a drop in revenue while you wait for a shared savings check. There's a pretty good pathway here.
So, Sean, what do y'all typically see as the role of the specialist in that? I get that it's very primary care based and very cornerstoned in that world, but what does an effective relationship with various specialists look like?
Yeah, that's a great question. One of the things I want to say is I think the whole country's grappling with that question. I know CMS is. CMS has been struggling to come up with a specialist strategy, and they're continuing to talk to people. What we found that works best is, especially in smaller communities where there's not just a professional, but often a personal relationship between the PCP and the specialist, is to sit down and have communication about expectations. In some of our communities, literally we invite the specialist in and we explain, we're doing an ACO. Here's why we're doing it. Here's what our goals are. And the goals of the ACO are really good for the patient. And so when the specialists see that, they understand. Like, they want what's good for the patients too. But what we find is PCPs often go into this conversation thinking they're going to lecture specialists. But if you're a neutral party in these conversations, you hear the specialists having very good demands of the PCPs too. When you send me a patient, be very specific about what you want. How many specialists get a patient walking in who said, Dr. So-and-so sent me? Why? I don't know. He just told me to come see you. So improving the communications and understanding what the expectations are. I'm sending you to the specialist for this very specific purpose. I want to hear back what the results are. I want the patient, an understanding of who's going to manage that patient. If this is if you're referring to a cardiologist, am I turning over management of this problem to the cardiologist, or do I just need a second opinion on something? When we've seen these two-way communication, we've seen some bonds form that are really fantastic, where the specialist now becomes a preferred specialist because they're seen as a partner, and their business does better. But I'm going to be frank with you. This is not true everywhere. I think sometimes distrust is too strong a word, but misunderstanding what the purpose of the ACO is. The other thing is, and this is where we're all trying to get better, is it's really hard to know who's a true high-value specialist. So the other thing is being transparent about the data. Here's what, Aledade, we provide our doctors data on specialists, outcomes, cost. But we encourage them to have a discussion with the specialist about it. And the typical PCP doesn't want to change their specialist, meaning switch. They want their specialist to be the most efficient and the highest quality. So I guess if I had used one word instead of rambling on, I would have said communication. The communication between the specialist and the PCP is so critical. And it's hard because everybody's so busy. Taking a step back and talking about what are we trying to accomplish here together is hard.
Where do you see the specialist being involved? Two-part question. Where do you see CMS going in terms of coming up with value-based incentives for them? And then where's Aledade placed? Is there any sort of financial model around that within y'all's ACOs?
Yeah, so I'll answer Aledade first, then CMS. At Aledade, we're experimenting. We have such a broad network now, in 40 some states. Before we roll anything out to all of our practices, we test it in some markets. So we're testing a couple different specialist approaches. One is, there are some companies that have started up that will give you real-time consults, by phone or technology. That's one pathway. Another pathway is literally trying to profile specialists in your community and create a preferred list of those who are signing compacts to work with the ACO who are shown as high value. But it's hard work. And so we don't have one single product we're rolling out across the country. We're collaborating with doctors locally, trying to see what works. And I think we're a small part of what CMS is going through. So I'll tell you, when I was at CMS, we got requests from all different specialty societies who all wanted a value-based model for themselves. So the orthopedists had some ideas, and the cardiologists and the nephrologists. And I think what CMS quickly learned is it doesn't have the capacity to create new models for every specialty. It has had its bundled payment for care improvement, which are, certain hospitalization and post-acute care bundles that are typically specialist oriented, but that's been a mixed bag. I have seen them out in the community. This is CMS folks talking to the specialists, talking to the ACOs, trying to find a path forward. I do think they're looking for some model where you could embed a bundled specialist model within an ACO. What gets really hard there is pricing it accurately. A number of specialist models that CMS has tried have had either overly generous prices or the price has been too low, and so you've seen results all over the map. But I think that's what you're going to see, is them trying to embed some sort of specialist bundles as an option or maybe mandatory within ACOs. I don't know. But that seems to be where they're headed.
Sean, in your response, I caught something that I want to ask you about. In your pilot programs, you mentioned, or at least I thought that you mentioned, a model that maybe you're looking at telemedicine and as part of that downstream in terms of specialists, consults, things of that nature. Did I understand that correctly, or is that something that do you see telemedicine playing a role in your models?
Yes, I think certainly telemedicine has a role, whether it's extending primary care or improving communications between primary and specialty care. The specific test that I was referring to is this group that is willing to, so if you're a PCP and you have a question about a patient's cardiac condition, you can get a specialist consult like within 10 minutes. And what the results we've seen from that are 2/3 of the time, what the specialist is telling the PCP is what you were planning to do makes sense. So it's just reaffirming the instincts of the PCP, but giving them some comfort. And then there's just a subset where they steer them a different way, like escalating the care or saying this person does not have, you don't need to refer them to a specialist. Obviously, that's one level of support you can give to PCPs. It's not a solution to how do we integrate specialty care and primary care better, but it could be an interesting piece of it. And what we found in this test, just because you asked, is there are multiple versions of this. The one our PCPs liked the most was the one where they got immediate feedback, meaning they didn't send the patient home and wait 36 hours to get some feedback from a specialist. And that's hard to do, but it seems to be essential, like to get that feedback while the patient's still there and they can change what they're going to do while the patient's still in the office. But we have a lot more to learn here. I don't want to suggest we solve this puzzle.
Sean, as y'all have, such the breadth that you do, obviously we deal with practices that are both urban and rural based. What differences have y'all seen in the operations of your ACOs, rural versus urban, and what allowances have you had to make for that?
Yeah, well, as I said, so one of the differences is the options for specialists, options for facility partners. In a rural community, the options can be less. The upside is there might be a personal relationship there. So you might be easier to communicate with the specialist and have that sit down and the talk. We love the rural communities, and we tend to operate more in rural communities than a lot of ACOs. And that's because we work with independent practices. And when you get into the major metropolitan areas, what you see is heavy consolidation, where the practices have been bought up by the big health systems. So that's one of the differences we see for us in the near term. The opportunity to work in some of the major metro areas is limited. Going back to your first question, though, I don't think that's a permanent condition. I think everybody's going to be pivoting to value at some point, and we will be working with people, employed physicians, health systems in the larger urban areas. I hope that answers your question, Mike.
It does. It does kind of bring me full circle back to a question John asked way back at the beginning. Do you see value-based care and the financial incentives of that being so great as to shift that move toward employment in the first place, to where independence is so much more financially attractive in the future that it just shifts that tide in general?
Yes, I do see that. We've seen small aspects of it. So think of the world three ways. You've got truly independent PCPs. You've got independent PCPs who've joined a hospital CIN, and you've got people who sold their practice to the hospital. Those people face three different landscapes. We work with the first two. Quite a few of the physicians we've recruited in the last two recruiting cycles are physicians who were in that middle group. They've been independent, but they've been working through the hospital CIN. So certainly we're seeing that shift, where hospitals are losing some of their CIN physicians because, and again, I hope this is temporary, they don't feel they have the clinical independence or the voice in that CIN that they would have working with Aledade or other independent groups that are truly physician-led. I think you've seen to a much smaller degree, the more extreme, which is in the third group, employed physicians, the ones who went either sold their practices or went straight out of training into hospital employment. But I don't think that means they're happy. We've talked to enough of them, and we think there's an opportunity, and we're exploring this. If those physicians saw like a turnkey solution where they could come out of hospital employment, what they don't want to do is look for real estate, have to buy an EHR. They want to practice medicine, right? Imagine a world where they could walk into an office tomorrow, they could have in place an EHR, staffing, and more important, value-based contracts for their patients. And they could build up a practice from a value orientation from the beginning. And they could pay for all that stuff that they were given through future shared savings. I think if someone, and be frank, this is something Aledade's kicked around, if someone developed a model like that, I do think you'd see that third group of employed physicians start to move out. Because I think they went into employment for legitimate reasons, but I think they missed their clinical autonomy and the ability to do the right thing.
Sean, I have a question in relationships specifically to the MSP, MSSP, and the successor models. We are seeing, at least with our client base, we're seeing a significant shift of the traditional red, white, and blue moving to MA. So we're seeing a decline in the traditional model and a significant increase in the MA. Long term, do you see there being continued long-term success for models that are associated strictly with the red, white, and blue?
No, I think if you want to be successful in value-based care, if you want to be successful in senior care specifically, you're going to have to be able to do both. You're going to have to be good at MSSP, which is the ACO program, but you're going to have to learn how to work in MA as well. And I think some practices don't want to hear that, and I don't blame them. Like the Medicare fee-for-service patient is their last patient where the insurer's not, requiring prior auth and all that. But the world is just changing. As you said, Medicare itself is still growing dramatically with the aging of the baby boomers. So senior care as a field is growing. But as you said, the part that's growing is the MA enrollment. Seniors choosing to remain in what I call traditional Medicare, some people call fee-for-service, they're actually declining somewhat in an absolute sense. So even as the program as a whole grows, the absolute number of people in traditional Medicare is going down. So we've talked in our practice quite a bit at this. If you're going to be really good at senior care, you're going to have to learn how to do MA. And at a clinical level, it's very similar, right? There's the same patients. It's more the STARS measures, getting good at that, and getting good at complete and accurate diagnoses, which is the risk adjustment part of MA. And as you know, that's where a lot of people trip up. There's some who get tempted and do fraudulent things. We're very careful to tell our doctors, we're going to do this the right way, and we're coaching them on how to do that today.
You've been listening to Beyond the Stethoscope, Vital Conversations with SHP. This has been a production of Strategic Healthcare Partners. Your news hosts today were Jason Crosby and me, Aaron Higgins. It is produced and edited by Nyla Wiebe. Our social media content producers are Nyla Wiebe and Jeremy Miller. And our executive producers are Mike Scribner and John Crew. For more information about SHP and the services we offer, including the back library of episodes, episode transcripts, links to resources discussed, and much, much more, please visit our website at shpllc.com. Thanks for listening. You already know that understanding your data is key to improving patient outcomes and financial performance. But how? At Strategic Healthcare Partners, our analytics services help turn your EMR and other data sources into actionable insights. From identifying areas for improvement to guiding you through implementing changes, SHP supports you every step of the way. Our performance analytics service dives even deeper, providing custom reports that help you stay ahead in the transition to value-based care. Unlock your data's full potential with SHP. Learn more at shpllc.com.